Good afternoon, and thank you for attending the 2020 Behavioral Health Symposium. We're happy to host this event as a virtual conference because we care about your health and safety. But we also understand how important it is to provide relevant content and robust continuing education to Louisiana healthcare professionals. For quality purposes, all participants will be muted during the presentation. If you would like to submit a question to a speaker, please use the Q&A feature in the virtual platform. This session is accredited for 1.25 hours for the following: social workers as a general credit, addiction specialists, peer support specialists, psychologists, nurses, contact hours, licensed professional counselors, AMA, PRA Category 1 credit. Full participation is required to receive credit and will be monitored throughout the session. You will receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Additional information is available in the digital event booklet. Regarding financial disclosures, Dr. Arwen Podesta does have financial disclosures which she will address in her presentation. None of the members of the symposium's planning committee or any session moderators have any financial disclosures. A little bit about Dr. Podesta. This session is entitled Addiction, Substance Use, and Recovery During the COVID-19 Pandemic. Our speaker this afternoon, Dr. Arwen Podesta, is a board-certified adult psychiatrist with subspecializations in addiction, medicine, forensic psychiatry, and integrated medicine. After completing her residency at Louisiana State University and a forensic fellowship at Tulane University, Dr. Podesta served as a medical director of the largest public addiction treatment center in the Gulf Coast South. She is a medical director of an integrative addiction intensive outpatient program and acts as a consultant for criminal court, drug court, and reentry services. Dr. Podesta's primary focus has been and continues to be access to integrative mental health and addiction treatment and rational prescribing practices. Dr. Podesta maintains an active role in the academic community as a clinical faculty for Tulane Psychiatry Residency, Louisiana State University Psychiatry Residency, and Tulane Addiction Medicine Fellowship. She has served as president of the Louisiana chapter of the American Society of Addiction Medicine. She was also awarded the honor of Distinguished Fellow of the American Psychiatric Association. And she has been voted into the ranks of New Orleans Magazine's top doctors on an annual basis. Again, thank you for attending. And without further ado, I'm introducing Dr. Podesta.
Thank you. Always fun to hear your credentials read by someone else. So that I do, all of that is true. So all of that is on this slide. So let's go ahead and get started. Okay, well, I am going to be talking about treatment barriers and what's going on with treatment here in Louisiana and around the country. It's really been devastating for many who suffer from addiction or who have even started using substances during this time. Here are my disclosures. So you can know that I do speak for certain companies and I'm on an advisory board for some companies. Okay, so we're going to go through, it's kind of a three-part talk today. So first, we're going to talk about what are the issues in a pandemic for those suffering from substance use disorders. And then we're going to talk about what the statistics are of substance use disorders and overdoses and awful things like that during the stats that we have so far during COVID, during the pandemic. And then we're also going to review barriers to treatment, but most importantly, we're going to end on a high note with solutions to treatment. So I'm excited to show you that this state and other states and federally, we've had some solutions. So that's great. All right, so we talk about the problem, then we talk about the stats, then we talk about the barriers and solutions. So problem. So the issues faced with individuals with substance use disorder, particularly during this pandemic. So first of all, we have to think of like who's vulnerable. What are some of the characteristics of those with substance use disorders, and how does the pandemic influence that? Well, we know that addiction is when someone uses substances on an ongoing basis and the person is not able to stop on their own, or they have problems with stopping, problems with using. And so what we know is there's two different types. Like there's people that are actively using that we're going to talk about, and then people that are in addiction treatment or have been abstinent for quite some time and kind of what their vulnerabilities are. So those that have been abstinent for a period of time or in early addiction recovery, like I see a lot of folks that are, have been in recovery for less than a year. And anytime there's a stress, anytime someone is under stress, that there's more vulnerability to relapse. And then this is one of the worst complicated stresses in many people's lives, because it also includes an element of feeling completely out of control, and not just out of control on the individual basis, but on the larger scale, on the international basis. And there's a vulnerability of relapse when someone's structured life abruptly changes. So for example, people that go to work every morning, and that's one of their tools for addiction recovery, and then people that, pick up their kids at a certain hour, and then people that go to a meeting every afternoon and have their phone calls and then have, activities with family, etc. And those are these structures that are just missing right now and have been for 6 months or more. And so things have been abruptly changed with folks and mental health in general, but also with addiction. And so really, I think about that as like, what's that? A need for quality to supportive services to maintain sobriety and consistency and employment and such. And so those that are in abstinence or were at the beginning of the pandemic are higher vulnerability for relapse. And we'll talk about those numbers. For those that are continued to use, and I'm thinking of everything. I'm thinking of alcohol, methamphetamine, opiates, heroin, pills, any range of substances. For those that are actively using, people in active use tend to be isolated. And so isolation can breed more use. More using can breed more isolation. It's kind of this worm Ouroboros or tail chasing. And so what is a problem is that we're pushing people more into isolation or requesting for safety. But those with addiction and active using have a pattern of isolation already. So there's this other problem where then they're more isolated, and so we have a harder time reaching them, especially when we have quarantine set in place. And then there's another issue, which is accessibility to medication, especially for medication-assisted treatment and opioid treatment, which is so at risk for overdose. And I'm sure that I saw some talk headings that were about medication-assisted treatment. So I'm sure you've already talked about that a fair amount. Okay, and then there's also other vulnerabilities. So those with substance use disorder, whether they're in active recovery or in partial or using currently, they're at greater risk of virus COVID-19 adverse outcomes due to increased health risks. Like they might have they already have increased pulmonary and cardiac problems because opioids suppress respiratory systems, smoking of anything, smoking of a drug, smoking of tobacco, vaping, compromises the lungs and heart. And then generally those in substance use disorder, active or recent past, have lower immune systems. A lot of people with low vitamin D, every single person I've checked in my treatment facilities tend to have low vitamin D, which is a partial risk factor for complications of COVID-19 as well. And then we also have problems with access to addiction treatment, because at the beginning we didn't know what was going on, and so some of the inpatient facilities limited the beds, and which they still have, and so there's restriction on the amount of treatment available for like inpatient settings. Anyway, many switched to telehealth platforms pretty quickly. I've talked to some people in the lobby that are involved in telehealth platforms, which is fantastic for keeping in touch. It's really difficult for people that don't have a smartphone, for a lot of individuals that might be using and don't have data. They can't afford data, that don't have a hotspot, don't have Wi-Fi. So that's really challenging for those, or don't have a computer. And that's a reality for many people in substance use. And then there's something called the Ryan Haight Online Pharmacy Protection Act, which was created in 2008 to regulate internet prescriptions. And so for those that are non-prescribers, it's not a big deal, but for those patients that are receiving a prescription, or me as a prescriber, it's a big deal. So the Ryan Haight Online Act also imposes rules about the prescription of controlled substance through telepsychiatry. And so this requires that any prescriber has to have a certain level of compliance, and they have to see the patient in person at least once every 2 years. So for new patients, say coming off of heroin, it would be impossible for me without restrictions lifted, and there have been emergency restrictions, emergency restriction loosenings that have been placed. And so it's impossible to do telehealth telemedicine, and prescribe a controlled substance to a new patient with the Ryan Haight Act, or the Ryan Haight Online Pharmacy Consumer Protection Act. But even before COVID, some of the restrictions were lifted in emergency settings. And so therefore we were able to do it in some settings. And now, spoiler alert, we got some solutions that the feds have in place. And so we're no longer suffering through that problem. So social isolation we talked about, and then there's this whole thing, think about people with financial instability, and then more stress. So the more stress, the more vulnerable you are for relapse, the more vulnerable you are, the more stress you have, and then the more relapse, overdose, etc. What about those that then got a big old check at the beginning of this? How many people with addiction have you heard say that money's burning a hole in their pocket? So there was a big flood of dollars spent at the beginning when we got the financial package at the beginning of that. So the $1,200 sometimes was spent on drugs, not rent. So that's a problem. We talked about the loss of daily structure, and then there was a fear about distribution and availability of medication. And so that has not come to fruition, but there was that fear, and there always is somewhat of a problem with that if there is lack of resources coming into the country. A lot of medications are made in other countries. So if there's a distribution and manufacturing difficulty. Okay, so those that are in methadone or opioid treatment programs that are receiving methadone or buprenorphine, traditionally those require in-person visits to clinics. Methadone in particular, and many of you have worked or work at methadone clinics, and so this will be, you'll be knowledgeable of this, but methadone requires, at least for a certain length of time, which is a pretty long time, daily in-person clinic visits. How are you going to do that when you're being asked to stay home, quarantine, not have any social engagement, not have any engagement? So the in-person requirement was waived for methadone and buprenorphine treatment for current patients federally, but each state can adopt stuff differently. So I'll give you another spoiler alert of barriers that were removed by Louisiana. Louisiana adopted this, and so we have some solutions for those that are struggling with trying to get methadone and buprenorphine. New patients, however, buprenorphine is allowed by telehealth, but not methadone. So a new methadone patient, someone that is coming off of opioid pain pills or heroin, they have to go into the clinic to get their initial methadone evaluation and treatment. So this is a tough thing to reach people when they can't go somewhere, or when they have to go somewhere, they might feel at risk. So it's complicated when you do the take-home methadone doses because those newly beginning methadone, so sometimes when we start methadone, we titrate them up pretty quickly to the appropriate level, the appropriate dose. And so that dose might not be 30 milligrams, so they go on day one, and they are allowed a maximum daily dose of 30 milligrams with like a 2 weeks of that same dose. And that might not be enough to cover them for opioid cravings. And so it's just a challenge. And so we have like it works to a degree, but not super well. And so even those that are stable, somewhat stable, newer patients, but not super stable, they're given a 14-day of take-home medicine, but it has to be the same dose. So if they're in a time, anyway, that's the details of that are very, it's cumbersome and it doesn't satisfy the patient need necessarily, but it is at least getting the foot in the door and helping them come off of opioids. So the state, like I said, our state adopted that, Louisiana, but some of our neighboring states did not. And so they are basically, there's several methadone clinics in some of the neighboring states that have closed down. So what happens when a methadone clinic closed down and they've got several hundred patients? Where do they go? And it's again, very troubling. Okay, there's also this, I don't want to get in the weeds here because this isn't that applicable to those of you in the audience, but there's this balance between the DEA, pharmacies, and doctors prescribing. And so some pharmacies feel like there's a cap on how much buprenorphine they can have in stock. And then some, the DEA doesn't necessarily have a cap, but they flag suspicious orders towards wholesalers. And so there may feel like there's a cap or a maximum. And so pharmacies, and I experienced this the first 5 weeks of the pandemic. I was having patients that were moving to other parts of the state, but they needed a new pharmacy and they needed their buprenorphine prescription or something else that was a scheduled medication. And the pharmacies, a couple pharmacies mentioned to me, well, we don't have room for a new patient anymore. We are at our cap for the number of patients we can have. Or the pharmacies are hesitant to overprescribe or overprescribe to a prescriber like myself that they might not know because I live in New Orleans and I don't prescribe to, somewhere far away in Louisiana. So we worked those through and there's no real cap, but it is, the pharmacies are allowed to flag any prescription they feel might be of a concern. And so that's fine. Patients just need to know that and we need to work with them. And so this kind of goes on into that a little bit more. Let's talk about harm reduction, which I know is near and dear to many of your hearts. So the access to harm reduction, think about harm reduction, it's usually face-to-face. It's usually either at a drop-in spot or out on a bus or on the street or, in some sort of mobile unit. So, and naloxone is terribly important for that. And so we had a little bit of a problem with giving naloxone out in the communities at the beginning. And I think we've compensated, most of the state health departments, certainly ours, have compensated and made it available. Think about first responders or, a neighbor that might have reached in to save someone and administer naloxone to someone before COVID. Now, many people are not going to, even if they know what an overdose is, they're not going to reach in and put something up someone's nose because of the virus, because of the fear around it. And so just a very concern, more barriers. All I'm doing is demonstrating barriers. Needle exchange programs. Though a lot of them were on hold or forced to close because of accessibility issues. And so with that in mind, we're concerned like, well, if we don't have clean needles, if a lot of folks are relapsing, which you'll see some numbers that are really stark. There's then the concern of the infectious disease infection spread, HIV and hepatitis C. And so it was interesting, some programs were able to utilize online ordering and mailing of needles to folks. And I don't have the contact now, but I do know that I think actually it's in the later slide set. So you can have the contact in case somebody wants to know about how to get mail order clean needles for people that are still using. All right, so stats and trends. Let's look at the comparison. Well, here we go. This is back in 2015 to 19. This is what was happening already. Overdose, fatal overdoses, usually with opioids or opioids plus something else. In 2015 and 16, it was increasing. It's still increasing in 16, 17, still increasing in 18. And then slightly, a teeny bit lower overdose fatalities nationwide, a little bit lower in 2019, right before all this. And so just to kind of be clear, drug type, usually about 70% were involving opioids, but not, it doesn't list it as specifically opioids. Well, let's look at what the opioid overdose stats look like overall anyway. And this is 2008 through 16. So the kind of more flat line, the blue one, that is natural and semi-synthetic opioids like opioid pain pills, hydrocodone, oxycodone, etc. And then the methadone has always been low. It's hard to overdose, not as common to overdose on methadone because it has such a long half-life and most people don't use with it. When they do use with it, if they use a benzo, they might overdose. That's usually the most common. And then the blue is, I'm sorry, we did the blue. The purple is heroin. So it was lower than methadone for opioid overdose back in 2008. And then starting in 2011, 12, it started surpassing the methadone overdoses and actually got pretty high in the 15s and 16s and 17s. And then the big one that we're really worried about is synthetic opioids. So synthetic other than methadone. Synthetic opioids being fentanyl and fentanyl analogs. And these are not the fentanyl that our anesthesiologists use in surgery. These are not the fentanyl patches that are given to folks from a pain management doctor. These are street illicitly manufactured fentanyl or fentanyl analogs. You've heard of carfentanil and other things like that, that'll, 100 times, 1,000 times stronger than heroin. And so it's projected to continue increasing. It's available. And it comes in through customs, but because the size, it's so small, like you imagine a bust for heroin in the trunk of someone's car, the amount of heroin in the trunk of someone's car, the same availability of opioid would be 100 to 1,000 times smaller than that if it was fentanyl. So you can package in a small quantity, but have it be so strong that it can be, people can get more through customs, etc. Anyway, so that's a whole nother talk. But this is the nationwide data on change of overdose fatalities from 18 to 19. And so we did this by state, or by region rather. So the West, you can see kind of what the numbers look like. Red is in the 80% and blue is is much less. And so it's very regional. I want to mention that that CDC collects data from, the last data we have from the CDC, it takes about 1.5 to 2 years to collect all the data. And so everything ends up having to be regional after the data that the CDC processes and produces. But the CDC collects stats from statewide, and so some states don't necessarily have good reporting systems. So some of these may be artificial low or not artificially high, but you can see some of the biggest concerns. Hawaii and North Dakota having the most severe cases of overdose in 2018 and 19. All right, what about Louisiana? So in July 13th of this year, the Advocate reported that the opioid overdose deaths just up here in East Baton Rouge Parish increased 93% from June through July compared to last year. So pretty stark. And this is, we have very little data. We mostly have journalistic data and ER and something called OD map. So I'm going to look at that in just a second too. All right, so here's some data from other states as far as the change. So just what I was showing about Louisiana, there we go, 93% increase in overdose deaths from last year to this year, June to July. We're looking now at changes. So the little arrows are the changes. So New Hampshire, actually New Hampshire had a really high overdose death rate in 18 and 19. And then they had taken their state treatment response funding and some of the other grant funding for opioids, and they implemented it very quickly. And they seem to, I've read about it, they implemented probably right before COVID, probably at the end of 2019, in response to their high overdose rates. And so because of what they implemented, they had a stark decrease, which is pretty impressive. So 48% decrease overall in March, April, May of 19 versus 20. So that's pretty cool. Whereas most other counties, cities, states had an increase. So you can just look through, think of where some of your friends and family are and think of what that looks like for them. And then this is the South and Central Atlantic region. So this is some of the other numbers. Again, all of them are up from last year. And again, another set of data. I'm just listing it state by state. You can look at it later, but all of them are up except for Washington State, which had a 41% decrease in overdoses, fatal overdoses from January through March 2020 compared to 2019. So that's really interesting. So Vermont and Washington, two opposite sides of the country, had a big change, negative. And so they are doing something right in their public health and prevention. Here's some just to map it. I like to look at visuals. So overall on the left, we had everything but New Hampshire went up, and on the right, we had everything but Washington go up. So you can see that. Okay, so the OD map, it's exactly what it is, overdose map, national data, and that comes from emergency services. So EMS and other public services and medical professionals are able to put in to gather that data before it even gets gathered to go to the CDC. So they're able to put it on the front end, and that's where some of the other national data comes from. But OD map is really great because it's really quick, it's in the moment, it's early. And they show the overall, this is national data. January, there was a 331% increase in overdoses. February, 170, March, 152, April, 89%. But on average, just January through April, increase of 20% increase of overdose deaths. So again, I'm not trying to convince you because you already know this. This is just the data to support this, but it's really impressive and amazing and scary. And I have seen more patients come to me trying to get off of opiates than really ever before when, or we get contacted, probably the main hotlines get contacted more right now because of all of this. All right, and so then we have these spike alerts, and the spike alert is where you have just an increase in, in the moment. And so it probably means that some fentanyl hit the market in that area, and that's really what we're looking at here. And so time periods with the highest spike alerts were April week 1, March week 2, and March week 5. And remember, this is only until the end of April. So we don't have May, June, July in here yet. So we have some big spikes. And again, it's usually when there was a big fentanyl shipment that made it to the area that gets mixed in with the heroin, or people flock to it for if that's their choice, but very few people. I do know patients that fentanyl is their main choice medication, main choice of reward. But for the most part, fentanyl overdoses tend to be people that get what's called a hot shot, where heroin has a little drop of fentanyl in it, and it just is or a little more than a drop of fentanyl in it, and it's just dirty heroin with illicitly manufactured fentanyl. So it's scary. All right, here's some, this is great because again, these are all not gathered from the CDC. These are individual journalistic articles from places like the Advocate and the Times-Picayune and things like that around the country, and where substance professionals, coroners, EMS were interviewed in different journal pieces. And so in Appalachia, which is a hotspot for opioids and methamphetamine, the chief medical officer said, of one of the treatment centers there, said that there's an increase in longly abstinence people, so people who have been long in recovery, who have relapsed during the pandemic. And I see that as well. Those individuals that are ill from the virus and then they relapse during or after suffering from COVID-related health issues. So I've seen this as well, and it's not really something I had thought about until I found this, and then I saw it myself, is that someone gets sick from the virus or has a scare. They might not even get sick, but they have a scare. They become vulnerable because of stress, and they might say, well, screw it all, like, why should I even do anything other than go back to heroin? And so it's happened to me a couple of times with my patients, but it is that increased fear and anxiety, lack of support system, when struggling with a new or distressing illness. In Kentucky, the EMS director believes that issues creating a disaster with a pandemic are isolation, lack of structure, and a large amount of cash, like we talked about from the stimulus checks, and those being problematic for those in recovery. And he or she, I'm not sure, also stated lethal overdose cases found with large sums of money in their pockets alongside illicit substances. How interesting. And then we're in Ohio, and the medical examiner issued a public health alert after there was an increase in fatal overdoses 48 hours after the Ohio government eased coronavirus restrictions. Maybe because it was a sudden weekend opening of restaurants and bars, and the dramatic change of reopening can be destabilizing as well for people's consistency and mentality. And then we're in Tennessee, and the health department director said they saw the largest spike in overdoses, over 400 in a month between April and May 2020, since the county began keeping track of ODs in 2019. So 400 in a 30-day period, that's too much. One is too much, but that's awful. So Addiction Policy Forum, which I encourage you, if you're not familiar with this group, they have a great website and some great educational materials, but they did a nationwide web-based survey for those that were involved in substance use disorder. And they found that 73 out of 1,600 folks that responded to the survey, 73% are those from patients with substance use disorder. And then 40% had a family member with substance use disorder. And then there were, you can see the demographics for Caucasian, female, and age. And 1 out of 3 responders saw significantly increased difficulty accessing their recovery or treatment services. So at least a third. I'm surprised it's even that. I'm surprised it's that little, because I would surmise it would be more based on my experience here in Louisiana. 14% said that they had inability to access needed services, and 2% talking about naloxone in particular. 4% said that overdose had occurred since the pandemic began. So this was 1,600 folks, 4% of them said that overdose had occurred. And 24% said that they themselves or their family members' substance use disorder had changed, 20% saying notable increase in substance use. And so, you know, there's a big need for peer support. We have 12-step recovery meetings. We have all sorts of other peer support, from churches to activities that is just an accountability and a therapeutic involvement, but it's not available in person. And in fact, at the beginning before everyone transitioned to virtual and was comfortable with Zoom all day, every day, we really didn't have access. So we'll get into what did happen and how we overcame some of those barriers. And so more about the survey, some of the comments were that there was no ability to socialize or connect. And I've always said that addiction is the opposite of connection. Addiction and isolation go hand in hand. connectivity and recovery go hand in hand. So the lack of connection is very disturbing and distressing. And the meetings now have been reduced to Zoom, and a lot of people don't feel supported by their peers and don't feel like they're getting a good recovery message. And again, Zoom, if you don't have a computer and you only have a phone and you don't have a hotspot and you don't have data, there's some issues with access. And the meeting of a sponsor is something that, especially, you know, those one-on-one meetings face-to-face are very important. All right, so I just wanted to throw in some trends in Canada, not different really, same overall look. You can see the graphs. Here's a little more, 17% overdose increase in BC. And so just some more info for you. So it's not just about US, it's really happening. The pandemic is worldwide. Opioid use disorder and substance use disorder is worldwide. And these trends are happening worldwide, but we have the stats that I just showed you from the United States. Okay, solutions, yay. This is where I like to sit, in solution orientation. Okay, so we are going to get into solutions. Okay, federal level changes to prescribing. So the feds, the DEA, but when I talked to you about the Ryan-Haight Controlled Substance Act, Prescribing Act, they were able to override some of that. So March 31st, in effect of the duration of the public health crisis, which we're still in, and we have no end in sight as far as it being a public health crisis, the DEA allows now the prescribing of controlled substances via telehealth. So it's overriding, or it's lessening the restrictions on the Ryan-Haight Prescribing Act. And we can have early refills of controlled substances, like Schedule II substances, which are things like opioid pain pills and stimulants for attention disorder. Those are Schedule II. And so usually we have to write one prescription for them and then write another prescription a month later after a visit. However, they have extended early refills and extended the ability to write a second prescription, multiple prescriptions for 90-day instead of 30-day. But they have to, there's criteria that have to be met, and I'm learning what pharmacies need what criteria and what insurances need criteria. And so it's just different. It's just another thing to navigate that's really challenging. And then the Schedule 3 through 5 controlled substances, buprenorphine falls into that. Methadone is actually Schedule 2, but buprenorphine falls into Schedule 3 through 5, and the pharmacies are allowed to dispense those early. So the DEA is encouraging leniency and reciprocity by states. So I'm licensed only in the state of Louisiana. I have patients that are going home to their families and staying at their grandma's house in Mississippi or in Texas, or, you know, farther away, not necessarily within our borders, but the DEA is encouraging leniency for reciprocity so that I can prescribe to a neighboring state without having a license in Alabama or Texas or California during this public health crisis. However, my license, and I know this doesn't apply, but this applies to a lot of your patients, my license is only, my license in Louisiana, I have to abide by what the Louisiana Board of Medical Examiners says. So I check with them. And for those, you might have a new client that's coming in and they're living in Louisiana and their doctor prescribing is, let's say, in Illinois. And so they might be getting a prescription from an Illinois doctor in picking it up at a pharmacy in Louisiana. And that Illinois prescriber needs to check to make sure that it's okay, so that their patient, your client, doesn't run out of medications that might be necessary. So methadone and opioid treatment programs, they are giving take-home kits. So states are able to let stable patients get up to 28 days of take-home medications for methadone, which is so different than the day-to-day go to the clinic and pick up the medication. For less stable patients, they can be 14 days, which is still pretty amazing. What is so great about methadone clinics, though, is that connectivity and that accountability and that daily visit and that lack of isolation. So there's something good that they don't go into withdrawal and they continue the medication, but they're missing that other piece that goes with the therapeutic part of the methadone clinic outside of the medicine alone. So, you know, there's another concern that I talked to you about pharmacy stuff. It's very boring, but with that pharmacy quota, or not really having a quota, but maybe having a cap, with people having methadone limited access in some states that didn't adopt this take home, a lot of folks are trying to go towards buprenorphine, and buprenorphine is something that I could write a prescription for once a month, as opposed to having them come to see me. And so a lot of people are seeking buprenorphine, but then, like I told you about my patient that went up to northern Louisiana, who the pharmacy said that they didn't have room for more buprenorphine. What happens if we just have more buprenorphine on the market and in the pharmacies and more prescriptions? So we're working with that, and the DEA is aware, and they're very, they're really wanting to make this work for everybody. All right, and I mentioned the telehealth alterations, and then the general OTP changes to new patient admissions. So interesting, if someone, I didn't know this until I wrote this slide deck, if someone wants to get into an OTP program or opioid treatment program to receive methadone, they were required to have a 1-year history of active addiction before they start the methadone. And so now it's lowered to just 6 months. So you're required to having used for 6 months actively. But that was an interesting little caveat that I learned. So what about controlled substance flow? So what about when we have an emergency hospital pop up? You know, in New Orleans, we have what we called the MASH hospital after Katrina, but we have the COVID hospital over at the convention center. Now they have to have prescriptions there. And so they have these emergency pharmacies that might need someone that's on buprenorphine that's in the hospital and needs to get buprenorphine. So where do we have this logistical balance to make sure that the meds are available, but it's not going to impinge upon distribution and other locations being compromised? So interesting thoughts to think about. It's just that we do have barriers, and barriers that I didn't even know some of them. But what about harm reduction? So harm reduction organizations are really doing a great job, vigorously operating, even in the pandemic, but they might not be able to do face-to-face. And so a lot of the centers have been closed, but the founder of the national nonprofit, this is the one I was going to tell you about, Next Distro. So if you want to get mail-ins, contact Next Distro. And locally, we have some great organizations as well. I'm not sure if they're doing mail-ins. Someone will probably tell me in the comments, hopefully. But there are lots of volume requests. They're receiving 5 times as many requests as usual due to lack of access to sterile syringes in general, and then lack of access to pickup sites. The map on the right, the purple sections have the areas of the highest levels of HIV and hepatitis C for needle sharing in 2017. And so there are programs that are aimed in those locations to really ameliorate some of that risk with clean needles. So let's talk about some of the ways that different localities have expanded services. So Maine. The governor issued an executive order for new needle and syringe exchange policy, which had barriers to it in the past. They really were anti for a while there. And the one-to-one needle exchange was lifted. So you had to give a needle to get a needle in the past. But now in Maine, they allow individuals multiple needles at a time to prevent further spread. And then in Indiana, the Division of Mental Health and Addiction is providing lock boxes. So just outside an opioid treatment program, that's like a methadone clinic or a general opioid clinic, and they're putting lock boxes in. So even though someone might be driving by or passing by to get treatment, they're getting lock boxes with their methadone in it. And that means that they can get they don't have to go into the OTP to get their daily methadone dose. And then the naloxone is actually being provided with that take-home dose, which is pretty amazing. In Chicago, Chicago Recovery Alliance, also another great program that I've worked with or that I've interfaced with, they offer sterile needles, naloxone overdose training through mobile van services. So that's a key, is the mobility, getting into the areas that folks are isolated. And what about some other states? So Pennsylvania, they had a program for record-breaking distribution of 6,000 naloxone doses to county jails. How amazing. And syringe exchange programs throughout the state, because during COVID, they had a pretty high spike. And then they have virtual weekly training sessions in naloxone administration to the public. So that's a really cool thing. Maybe we can adopt that. And in Massachusetts, one of the police departments created a partnership with a substance organization for a survival kit to be given out, which has safety information, naloxone, referrals for local treatment services, referrals for telemedicine, and information on fentanyl. So public health is really getting involved because we have funding from the previous several years grants to the states for increased awareness of opioids. And then we have a pandemic, and then we have an opioid pandemic as well. So it's all working to better public health, still seeing some issues. I'm really looking forward to when the stats are gathered for since these things have been implemented, which is like March, April, May, these things have been implemented. So I'm really looking forward to comparing the stats that I showed you in the center, in the middle of this slide deck, comparing that to July, August, September through the end of the year, because hopefully some of these great public health services will have addressed the problem and decreased again. In Rhode Island, they have a comprehensive outline as to where to access sterile needles and access some mental health supports and available treatment options for OUD. And hopefully you guys have looked at the Louisiana Department of Health and individual city departments of health websites, because Louisiana has done a great job of providing resources for at least telling people where they can go to go get certain things or to call for mental health addiction services, and I believe clean needles, but I'm not sure on the state level. And then in Virginia, there was a harm reduction coalition that was able to ship free boxes of naloxone to volunteers around the state, who then put them out into the most concerning areas. And then in Washington, an addiction treatment clinic was providing services outdoors and also giving naloxone distribution and clean needles with a needle exchange program. So cool stuff. So, I hope that it doesn't take a pandemic to make these things happen, but it's certainly improving some of our public health, maybe putting a deep lens onto some of the needs for the public health issues. Mail ordering and distribution of harm reduction items. So lots of states have partnered with community organizations for mail ordering of naloxone and sterile needles. And then online overdosing tracking system. The OD map is a huge piece, but the state health departments have created dashboards. So when you look at your city or state health department, you see COVID numbers, COVID cases, COVID deaths. I think that all of the states have added that to their dashboard, and then many of them used to have ODs, but many more are having ODs on the dashboard now. Okay, so what about opioid use disorder specific? And so there's doorstep deliveries in Washington, New Jersey, and Ohio of buprenorphine and methadone. I have a couple of pharmacies here that are doing just door delivery, so private delivery. It's not through the mail. You don't want to send a scheduled medication through the mail, unsigned for or unknown, but doing a door delivery is great. Virginia State Medicaid increased flexibilities to expand telehealth coverage so that those of us doing telehealth, which many of you are hopefully getting Medicaid reimbursed. That's at least in Virginia, they did that. And our Medicaid program has done a pretty good job of expanding and waiving some of the requirements for telehealth. So that's been great. Seattle methadone clinics continue to increase use of telehealth. One clinic in Seattle started a mobile methadone unit to see new patients in person. So they abided by that one requirement that methadone had to have a new patient visit done in person. But they're also collecting extra data to allow for take-home methadone for patients. And then other states, New Hampshire, they have done publications with these state guidebooks, and they're really good. And again, New Hampshire, as I mentioned, was one of the ones where COVID cases actually have gone, not COVID cases, that during COVID, opioid overdoses have actually decreased compared to last year instead of increased compared to last year, like almost all the other states. And then Colorado, their Consortium for Prescription Drug Abuse Reporting Treatment Centers takes people from IOP and OP resources to virtual delivery. So basically they get medication and treatment virtually. Also they expanded methadone with curbside delivery, and then they have increased use of telephone check-ins. And so that's something that some of our case managers here in Medicaid Louisiana do as well. What about Louisiana? So methadone clinics did adjust to those federal guidelines so they could have fewer people through the door and longer take-home doses. Capital Area is Capital Area Human Service District. They're continuing injections, and by injections, I mean Vivitrol, which is an opioid blocker, which is a monthly injection of naltrexone that helps folks decrease cravings and helps them not use. And also Sublocade, which is an extended release buprenorphine that's once a month. And so they're really helpful medications. We continue to do them in my clinics and both my private clinic and at the IOP that I work with. But Capital Area is doing them, but they're seeing their patients just like most of us are, seeing their patients virtually. And then harm reduction advocates are providing Narcan clean needles and sterile smoking devices. In August of 2019, that was the worst year for overdoses in East Baton Rouge, waiting for the 2020 stats, we'll see. The LDH website currently has OD up to date as of 2019. So I don't see those stats yet. I believe they'll compile them at the end of the year, at the beginning of next year. All right, and so we have some national court associations. So drug court, I work with drug court, reentry court. I consult with some of the specialty courts. But the National Association of Drug Court Professionals, which many of you probably are part of, they issued a pretty great library of resources with free webinars and trainings for courts on how to adapt and modify the court procedures in light of the pandemic. Because we also have this expected increase in substance trends. New Hampshire Drug Court, again, New Hampshire, their numbers went down this year instead of up. They have expanded telehealth programs for substance use disorder offenders. Some places I've seen, and this is the individual court, not everybody, but some places I've seen that they have been able to give people through some resources, give people like a iPad or I don't know, notebook or something, or some sort of accessibility so that you're not looking on this little screen or trying to just have a phone session with someone, but actually do a, actually like have a better video for the individual to do their Zoom, et cetera, meetings on. And so they are having courthouse virtual meetings. This is cool. You know, at the beginning, I was worried about drug testing. And so a lot of my patients, even now, are really not getting drug tested. I'm seeing them virtually. There were some ideas about mail home, like the lab could mail a drug test to someone's home, and then they would do it on video. So the nurse watches them do the drug. I'm doing this because it's a cheek swab. They wouldn't watch them urinate. But the nurse would watch them do the cheek swab, put it in the tube, put it in the envelope, and then mail it off. And insurance wasn't covering that. And so that became a problem. And so we just never got that going. But in New Hampshire, they're using the sweat patches, which is really cool. It's a little expensive, but being that it could be covered, it's worn for 7 days to test for just a couple common drugs. And so it would only be worth it if the patient was using the type of drug that are on the sweat patch, which I don't know exactly what each patch does. And then they have mandatory group meetings for offenders, which is really cool, especially since isolation is so taxing on people with substance use disorder. All right, private online research resources and educational resources. This is great. So I mentioned, I don't have it on here, but I mentioned the Addiction Policy Forum. They not only have some great videos and great resources that you can share with your patients, with your clients, but they also have a wonderful non-biased access into treatment facilities, like how to get into a treatment facility and what they know what's open. And so they keep it cataloged. So frequently when someone is trying to get someone into drug or alcohol treatment, you start a Google search, and the Google search, the things that rise to the top are money-making for-profit organizations that may not have evidence. You don't know because they're not advertising their evidence. And so Addiction Policy Forum is a non-biased place to seek treatment for those. There's a national 24/7 web-based resource center, Not One More, really useful. Also similar, how to treat, and it's nonprofit. Ways to access treatment, naloxone administration, something called Monument, and that provides personalized treatment planning with therapists and physicians. Pretty cool. And then Smart Recovery is a great tool for patients, and there's an app where they have free meetings that are cognitive behavioral therapy based meetings. And they also have empowerment talks and trainings, and really great resource there. It's self-management and recovery training, Smart Recovery. And then In the Rooms is the online 12-step community. It has an app that's available. There's 650,000 or more members that utilize that. And so I tell my patients, like, if you wake up at 2 a.m. and your mind starts cycling and you can't call your therapist and you can't call your sponsor and you are starting to think, maybe I should go get something, just go into your app In the Rooms. Someone, maybe it'll be a meeting that's happening in Hawaii and that it's bedtime for them. And so you have access 24/7 to these meetings with some of these resources. And then we have a couple more solutions. So we have funding and applied prevention and resource. So in February of 2020, the Office of National Drug Policy and the CDC partnered, and they provided nationwide funding for substance abuse prevention, $25 million for community level organizations involved in preventive measures for youth substance use disorder. I know some folks that have gotten some of or have applied. I don't know if they've gotten the grants yet, but they've applied for some of the grants for some really great startups, really wonderful community-based preventive solutions. And that allows 200 communities to receive direct financial help from the White House to implement these measures. And then the Rural Health and Safety Education Competitive Grants Program. So there's funding for community-based outreach for health and wellness. And the projects have to emphasize telemedicine, telehealth, distance learning strategies for education to minority rural communities in opioid treatment. Very specific, but it's widely needed. And then there's more research funding on opioid use disorder in minority populations. I want to mention that opioid use disorder is what we talk about so frequently, but as many of you know, methamphetamine is the next wave. And so not that opioids are going away, but we're going to see more meth, and I'm seeing more meth in our communities here in Louisiana as well. So we really want to make sure that everyone in the treatment chain is aware of the federal policy changes. I know some of the stuff I read to you or told you was pretty boring, but it's really helpful to know what your client or patient is going through and what some of the barriers have been to their treatment and maybe what some of the changes are so that you can help monitor that. And really know what makes individuals with substance use disorder more susceptible and create preventive measures. I try and be creative with some ideas with patients, talking to them about using in the rooms in the middle of the night if they wake up, and then talking to them about, just distance visitation with their sponsor somewhere at a park or something, talking about exercise, talking about things to help alleviate some of their fear and stress overall, which makes them vulnerable to overdose and relapse and overdose. And then understanding the states and counties measures and who is the most vulnerable. We really need that real-time tracking. Some of the cities in Louisiana do have real-time tracking. I'm looking forward to that being more adopted. And then more quality in treatment and supportive services during times of isolation, figuring out how telehealth works, figuring out how it doesn't work. It doesn't work for many, and some people prefer it. Actively calling people that are struggling, even calling your peers, having safe home visitations. I know some home nursing is doing that. And then more collaboration and open dialogue between clinicians, treatment centers, community program leaders, and state agencies, and just being able to foster more communication, which is what we're doing today. So I'm glad to be seen by all of you. I'm not seeing anybody, unfortunately. And so I always talk about the continuum of care that's needed from the lowest level to the highest level and the circle that goes around. So with that, I am open to questions. Do you have any questions for me so far? So I believe you want to put questions in the...
Questions go in the Q&A box in the Zoom feature. But we don't have any questions right now, but we ask that you send them in. Make sure to put them in the Q&A box and not the chat box. So thank you, Dr. Podesta.
Yes.
While we're waiting, well, we do have one that just came in. I'll save my question. So Christina Little asks, are there naloxone distribution programs to certain populations that are more effective than others?
So unfortunately, just having the data doesn't show me efficacy. I have some of the states that were putting them in, that were sending them from the center, the state hub, and sending them out to communities that were most hard hit, those purple areas that I showed you that had the HIV and HCV hardest hit. So getting those into those communities and then being able to be mobile and accessible in those communities, I would imagine are most accessible and most effective because of what we know. But this data hasn't come through on that yet. But I think that's a really good question that I hope I can answer next time after we have some more data.
Great. Another question from Laura Garcia. What is the increase in January related to? Are the deaths higher during holidays?
Yes. So yeah, so we did, remember, many states, we did not experience our pandemic shutdown until mid-March, but many states did. And there were a lot of folks in areas that maybe weren't experiencing a shutdown, but were hearing the national and international news and were very fearful. And so when we're thinking of some of the earliest hit states, New York and Washington, we think of January as the start date. But at the same time, when schools are out, when holidays are in, there is a higher risk of use, whether that's, partying jovially and accidental overdose, or using isolatively and accidental overdose. It does happen more around those times.
Okay, great. I think our next question was very similar to that one, if not the same question.
Okay.
About the increase in January. So any more questions from anyone else? Go ahead and put them in the Q&A box. So I have a quick question.
Yeah.
I know you talked a little bit about some of the programs that are ongoing in Louisiana. Could you speak a little bit more about maybe the top 3 that are actually occurring now?
Well, that's yes, a little bit. There we go. So the top 3, I can't really say what are the top 3 as far as numbers go, but I know that for those with even before COVID, there were expansions going for those with opioid use disorder. And so there are treatment centers throughout Louisiana that are accepting patients, clients, patients and so we have to break it down by a residential treatment program. And in my area, we have a lot of folks that are still getting into Odyssey House Detox, going to Bridge House if they have Medicaid or don't have funding, and then the private locations that for those that do have private insurance or funding. And then there's PHPs and IOPs, intensive outpatient programs, and there are more than fewer now. And there's some have kind of shuttered because they weren't getting good reimbursement, but there are in Baton Rouge, there are several IOPs, and in fact, Capital Area has an MAT program, a medication assistance program, and LSU, Our Lady of Lake residency program, is having a MAT program for buprenorphine. Also LSU, New Orleans at LCMC. And then certainly true in other parts of the state as well. But we have expansion. Our state Medicaid has done a great job of improving expansion and accessibility. And it's just getting into those services. Yeah.
Our next question is from Trishelle Dumas. Are there any specific recommendations for IOP programs?
So I don't know. I mean, there's loads. So there's IOPs that are involved with medication-assisted treatment, which I think is really useful, and that's what I prescribe. And I work at ACER, and Townsend that is now called. Someone help me out, guys. Is it called Avenues now? Please tell. Or I'm sorry, there was a change in ownership, and I apologize. But there are places throughout the state. And to be honest, with those that have virtual programs, you can get medication-assisted treatment, like I showed you before, without the counseling, without the group counseling. You can get medication-assisted treatment at certain places like Capital Area and at Metropolitan Human Services and LSU clinics. And so because they do a lot of stuff virtually. So good question, Tishal. I'm not shilling for any particular organization, but I do work with ACER, and they are open in Baton Rouge and Metairie and Slidell. And there are loads of other clinics and IOPs that are available.
Thank you. The next is not a question, but more of a comment. Belinda Bergeron says that her company has pretty good success with helping people get into rehabs in Louisiana. So thank you, Belinda.
Belinda, what's your company so that we can let people know, for those that are asking? We can put that out somewhere. Yeah, that's great. Well, are there any other questions? I think it's wrap up time.
Yeah, right now there are no other questions.
Great.
So yeah,
thank you so much, you guys. It's been a pleasure. I wish I was in the room with you, but this is the next best thing. So thank you, and keep taking care of the folks that you're doing such a great job taking care of.
Thank you, everyone.